Welcome to the research plenary at CAPE 2019. We apologize for the delay, and we're happy that you're able to join us this morning. My name's Andrew McRae. I'm the chair of the CAPE Research Committee, and I'll be moderating the session today. It's my pleasure to be your host for the top 4 research abstracts of this year's competition. We had 335 abstracts submitted for consideration this year. And after a rigorous peer review process, I'm sure you'll agree that the 4 presentations that you'll see today are worthy of being on the stage at the research plenary at any research meeting anywhere, because Canadian emergency research is the best research in the world. I am going to start by introducing the top-ranked abstract of this year's research abstract competition, and introducing the recipient of the Grant Innes Paper and Presentation Award, Dr. Jeff Perry from the University of Ottawa, who will be presenting a validation of the Canadian TIA score, who's at risk for subsequent stroke following a TIA or non-disabling stroke in the emergency department.
Great. So good morning. It's a pleasure to be here today to present the results of our study. I'd like to acknowledge my co-investigators, many of whom are here today, as well as funding from the Canadian Institutes of Health Research. I have no conflicts of interest to declare. So transient ischemic attack, or TIA. This precedes about 15 to 20% of all strokes. Hence, this is an opportunity for preventative interventions to improve outcomes and improve survival. Current scores to predict high-risk patients have performed poorly in subsequent validation studies. Our group has previously derived the Canadian TIA score in a prospective cohort of over 3,900 patients at 8 sites. So why is this important? Well, previous emergency department studies have shown that with patients with an emergency department diagnosis of TIA, that the risk of subsequent stroke is about just over 10% by 90 days. Half of these patients will have a subsequent stroke within 48 hours, but if you look at the very beginnings of the slope here, it's very, very steep until after about 7 days when it starts to level off. So the risk is very much front-end loaded, so it's very important to identify patients at high risk early. Previous studies have also demonstrated that for patients where carotid artery stenosis is the cause of their TIA or stroke, that early intervention is very, very important to improve outcomes. But what patients are at high risk? Well, our group, as I mentioned, has previously conducted a prospective validation score of the ABCD2 score in over 2,000 patients. We found that the ABCD2 score, which is probably the best known score out there right now, was not sensitive enough or specific enough to be the sole predictor for identifying high-risk patients. Our group went on to derive the Canadian TIA score, which was published in Stroke in 2014. And so what the Canadian TIA score looked like is basically took 9 clinical findings and 4 variables for investigations to give a final score between -3 and 23. So the objective of this study was to prospectively validate the Canadian TIA score in a new cohort of emergency department patients with TIA or non-disabling stroke. So this is a prospective cohort study. It was conducted at 14 high-volume urban Canadian emergency departments from 2014 to 2018, and these included both academic sites and community sites. We enrolled consecutive emergency department patients with TIA or non-disabling stroke 7 days a week, 24 hours a day, 365 days a year. And we excluded patients where the symptoms had already been there for over 24 hours, if they had a clear stroke mimic, or they were administered TPA as part of a stroke code protocol. Physicians completed our data collection forms, which included all the elements of the Canadian TIA score, as well as the total score and the degree of risk. Our research staff collected results of investigations, admissions, consultations, and they also conducted telephone follow-up at 7 and 90 days using a previously validated questionnaire. Our outcome was subsequent stroke or carotid revascularization within 7 days. Our outcomes were assessed by blinded adjudication committees at our individual sites, where 2 stroke neurologists usually and 1 emergency physician very comfortable in the diagnosis of stroke adjudicated these cases blinded to the data collection forms, or what the KNTI score had, and all the information from their initial visit. And basically they looked at any cases where there's either a positive answer on the telephone follow-up, or any of the follow-up medical records indicated that there might have been a subsequent event. So our analysis included descriptive statistics, univariate analysis, and calculating the interval likelihood ratios with corresponding 95% confidence bands, as well as the probability of subsequent stroke or carotid revascularization within 7 days. Our estimated sample size was just over 5,000 patients, including 93 patients with subsequent stroke. This is what our data collection form looked like. So in terms of our results, so of 9,398 eligible patients during the study period, we successfully enrolled 7,569, or about 81% of all eligible patients. The missed eligible patients were very similar in terms of sex and age and final diagnosis. In terms of patients being lost to follow-up, there's just 8 where we did not have any telephone follow-up or subsequent clinic visits at 7 days. In terms of our final outcome, we had 181 patients who either had a subsequent stroke or early carotid revascularization, of which 107 were subsequent stroke and 74 were early revascularization. So this corresponds to an event rate of 2.4% at 7 days, and increased to 4.3 by 90 days. In terms of our univariate analysis, so if you look at the second last column, you'd see that essentially clinical features of weakness, so whether it be face, arm, leg, pronator drift, or the composite of all of them, or any speech difficulty and dysarthria were all strongly related to stroke, as were elevations in blood pressure, CT findings of acute, old, or any infarct, as well as if the patients were already taking ASA, were all strongly associated with our outcome. So this is the so-called money slide here. All right, so essentially here we found that patients at low risk, so Canadian TI score of -3 to 3, had an interval likelihood ratio of just 0.2, or a corresponding probability of a subsequent stroke or early revascularization at 7 days of less than 0.5%. It's a very low risk patient group. The medium risk, so Canadian TI score 4 to 7, they had an interval likelihood ratio of 0.8, or probability of 1.9% of a subsequent event at 7 days. And the people at a high risk, so 8 or more points on the Canadian TI score, had an interval likelihood ratio of 2.2, or a corresponding probability of 5.2% of having a subsequent stroke or early revascularization in that group. So the Canadian TI score accurately identified emergency department TIA patients' risk for subsequent stroke or revascularization within 7 days. We feel that low-risk patients can be safely discharged following careful emergency department assessment with routine follow-up. We also feel that moderate-risk patients should undergo additional testing in the emergency department, so the bare minimum ECG, CT head, vascular imaging when they're in the emergency, as well as optimizing the antithrombotic therapy, so DOAC or warfarin for atrial fibrillation, as well, and then either monotherapy or dual therapy with antiplatelets, and also have early specialist follow-up. And finally, the high-risk patients should be fully investigated and managed in consultation with a stroke specialist during their index visit. Some limitations: this was an observational study. As such, we were not able to change how physicians were managing their patients. So there was some variation between individual physicians, between sites. And we followed this, but we were not able to control for that. We did not adjudicate the side of the carotid stenosis with an intervention to see if it correlated with the stroke symptoms. However, these were specialists managing these patients, and since it wouldn't be indicated to intervene on the other side, we're hopeful that there wouldn't be very many where they're misclassified. We have not yet completed the refinement step. So a refinement step is a methodological requirement in creation of any clinical decision rule or prediction score, which you try to improve the sensitivity, specificity, or the simplicity of a clinical model. And we're nearing the end of doing that process. And unlike other emergency department conditions, the KNTI score will not give a 100% sensitive model which directs care, but rather it'll identify patients that are high, moderate, or low risk, for which the patient, the individual physicians, their physician groups, or the patients may dictate what level of care, what degree of investigations are done at the time of the initial visit. So in conclusion, we have successfully validated the KNTI score to identify patients' risk for subsequent stroke or carotid revascularization within 7 days. It is anticipated that the KNTI score will optimize resources to ensure maximum investigations and therapies are directed at patients at the highest risk for subsequent early stroke. So I just wanted to say thank you, a shout out to all of our neurologists, emergency physicians who adjudicated the outcomes, as well as all the physicians, nurses, residents who completed our data collection forms at all of our 14 sites, and our research assistants and nurses at all the sites in our coordinating center, without whom we couldn't collect all this data. And a special thank you to Angela, Jane, Connor, and Mary Jo. So thank you, and happy to answer any questions.
If you have questions, I'd invite you to come up to the microphone so that we can see.
Yeah, because we can't see very easily from up here.
Eddie Lang, Calgary. Congratulations, Jeff. This is fantastic work. I look forward to seeing it in publication and embedded into guidelines. For the low-risk strata, there were relatively few events, and makes me think about the precision estimate around the 30-day risk of stroke. It's listed in the table as less than 5%. Do you have confidence intervals around that, or is that included in that less than 0.5%?
Yeah, so we don't have the confidence intervals, but if you look at in terms of the numbers, it's not up there. But I don't know, are you able to project that slide? It's up there now. So here we did break it down per strata, and essentially certainly the numbers are very small. So you're right, you will have bigger confidence bands, but there are so many patients with a negative outcome that it is pretty solid that these people are definitely at low risk. And truthfully, likely many of these are actually stroke mimics, and which are being labeled as having TIA.
Thank you.
Jeff, did you make an attempt to compare it to the current crappy scores that we have?
So we have looked at their ability to predict, but we haven't done a direct head-to-head with the new analysis that we've just completed, but that is in our plans, yes.
Hi, Jeff. This is great stuff. I'm going to ask it from an American point of view, where MRI is so dominant. The Americans have shown that if you do an MRI at 24 hours, up to 20-25% of people with TIAs have actually had strokes. Since one of your outcomes is stroke, how do you get around the questions that are going to be raised? Well, you didn't identify all the strokes that were not TIAs, that were actual strokes. And how do you incorporate your rule into that bias in the States about MRIs?
Yeah, so good question, Jim. So essentially, the part of the problem is the definition of TIA. So this study was being applied to TIA or non-disabling stroke. So patients, that's how we essentially get around that issue, or we deal with that issue, because most places, even in the U.S. and definitely in Canada, except Quebec City, most people can't get an MRI immediately. So it's rarely done, so you don't see if there actually is an infarct there or not. With the newer definition that's proposed for stroke, it would be anybody with symptoms for greater than an hour and with positive imaging, would then be classified as stroke, whereas the WHO definition of TIA says anybody where the symptoms resolve within 24 hours. So we essentially do recognize that some of our patients will have actually had small strokes, but our outcome was subsequent stroke. So it wasn't counting those people and saying, oh, well, you evolved and you actually had a stroke. That didn't count as an outcome. We were looking at people who had a subsequent event. And we previously presented this at SAME, and the Americans were actually very receptive and interested in the results. Great.
Congratulations and thanks very much. So, thanks very much and congratulations, Dr. Perry. I'll next ask to come up, happy to introduce Dr. Ian Steele from the University of Ottawa, who is going to be presenting the RAF2 trial, a randomized comparison of drug versus electrical cardioversion for acute atrial fibrillation.
Good morning, everybody, and thank you for getting up early to come and watch these presentations. It's a real honor to be able to talk about the RAF2 trial. And I want to acknowledge our many co-investigators that helped us run this study. It was coordinated by the University of Ottawa, but in collaboration with 7 other Canadian universities. We were funded by the Canadian Institutes of Health Research, and we don't have any conflicts. We're talking about acute atrial fibrillation, which is the most common arrhythmia treated in the emergency department. And we define it as symptomatic acute onset episodes of AF where cardioversion is an option, which most typically means the onset was clearly less than 48 hours. And these can be either a very first episode or recurrent episodes. In Canada, we tend to be fairly aggressive. We tend to cardiovert most of our patients. But there has been, according to previous studies, pretty much clinical equipoise amongst our colleagues as to whether to initiate cardioversion with a drug like procainamide or to start with shock. So our objectives of the trial, our primary objective for atrial fib patients was to compare pharmacological cardioversion followed by electrical cardioversion, ECV, if necessary, the drug shock approach versus ECV alone, the shock-only strategy. We had several secondary objectives looking at atrial flutter patients and comparing anterolateral to anteroposterior pad positions, but I'm not presenting those results at this meeting. So this was a randomized, blinded, placebo-controlled trial, 1-to-1 allocation comparing the 2 rhythm control strategies conducted in 11 emergency departments of large tertiary Canadian hospitals, and we enrolled stable adult patients with acute AF where the onset was either less than 48 hours or could have been up to 7 days if they were anticoagulated. We excluded those in permanent AF who were unstable or where a rapid heart rate was secondary to medical causes. All patients signed informed consent. And allocation was by a central web-based randomization procedure stratified by site. In the drug shock group, patients received a blinded infusion of procainamide at 15 milligrams per kilogram over 30 minutes, followed after a period of 30 minutes, if necessary, ECV at 200 joules times 3 shocks. Shock-only group received a blinded infusion of saline over 30 minutes, followed, if necessary, by ECV times 3 shocks. And we had distributed standardized AF management guidelines in terms of disposition, follow-up, anticoagulation, and all doctors were encouraged to use the same guidelines. Primary outcome was conversion to and maintenance of sinus rhythm for at least 30 minutes at any time after randomization. Secondary outcomes included disposition, adverse events, status at 14-day follow-up. I want to acknowledge our very brilliant biostatistician, Monica Talliard from the University of Ottawa, who oversaw the analysis, which the primary was intention to treat by chi-squared testing. We did a secondary modified intention to treat that I'll show you in a minute. we also did an adjusted analysis. We estimated we'd need 396 patients to detect an absolute difference between the two study groups of 10%. So, in the end, we did randomize 396 patients distributed as 204 in drug shock and 192 in shock only, and no patients were lost to follow up for the primary outcome, which occurred while they were still in the emergency department. You can see the characteristics of the patients in the two groups were fairly similar. Age, onset, over 60% started within 12 hours, and 45% or so had a CHADS-2 score of 2 or greater. And you can see at least 2/3 had a previous episode of AF. While they're in the ED, characteristics again were similar except for a slightly increased proportion on the shock-only group with a slight bump in their troponin. These were the baseline troponin, so they weren't influenced by management. This is the intention to treat analysis of the primary outcome, drug shock, 96.1% conversion, shock only 91.7% conversion with an absolute difference of 4.4%. And the p-value, to my dismay, was 0.07. If it had been 0.03, I might have been up before Perry, but anyway. Such is research, right? So looking further at our intention to treat analysis of all patients that had been randomized, you can see how their course played out in the two groups, and not surprisingly, a lot more patients in drug shock converted by drug infusion. Disposition home, similar, extremely high rate of discharge home, 97.1 and 95.3. We did an adjusted logistic regression analysis, and the odds ratio did favor drug shock, but it was not significant. Now, my more favorite analysis, the modified intention to treat analysis, we excluded 18 patients who converted spontaneously. This was after randomization, but before the start of the study infusion. And this analysis had a slightly significant difference favoring the drug shock group. Adverse events, very important, and you can see that the drug shock group was much more likely to have an adverse event in the ED, which was primarily a transient hypotension, defined as SBP less than 90, usually requiring a small bolus of fluid, but 8% required their infusion to be discontinued. And adverse events during or after ECV were similar in both groups. We had patients follow up or were contacted by phone at 14 days. We had one death in a patient who had terminal cancer. Unfortunately, there were no strokes, and the ECGs done at 14 days showed that 95% were still in sinus rhythm. Subgroup analyses here, comparing the drug shock to the shock only, and bars to the right favor the drug shock group, and you can see, that drug shock was favored in those patients who had a first episode or who were under age 70. So what we've shown is that both strategies are highly effective, and 96% of patients went home and 94% in sinus rhythm, which confirms the current Canadian standard of cardioversion in the emergency department. Procainamide converted 52% in a median of 23 minutes. Drug shock was more effective if it was a first episode or the patient was less than 70 years of age. Drug shock did have more adverse events, usually transient hypotension, and at 14 days there were no strokes and 95% were still in sinus rhythm. We believe that drug shock has some advantages. I want to put this in context of two recent trials. Schaumeyer and I'll randomized 84 patients and found that both strategies were quite effective, but there was a reduced length of stay in the shock-only group. Plenary had a recent trial which was quite different actually. While they employed both chemical and electrical cardioversion, they didn't compare them. Their comparison was cardioversion today or come back and we'll cardiovert you tomorrow. So we didn't directly compare ED length of stay, which was difficult to do because of the placebo infusion, and also we noted many times the electrical ECV had to be delayed while the team or the lead physician was busy with another case or a trauma. 92% of patients were reached on day 14, but all had the primary outcome assessment. We did have a lot of patients who refused to do the trial because they'd been through it before and had their favorite type of cardioversion, either procainamide or ECV. So in conclusion, both the drug shock and shock-only strategies were highly effective, rapid, and safe in restoring sinus rhythm. A drug shock strategy was more effective for patients with the first episodes and those under age 70. Drug works for 50% of patients, avoids the resource-intensive procedural sedation required for ECV. So bottom line is that immediate rhythm control in the ED leads to excellent outcomes for patients with acute AF. I want to thank lots of people, all the doctors, nurses, and RTs at our various study hospitals, our research staff, and the Data Safety and Monitoring Committee, which was at Western University. Thank you very much.
I just like being a shit disturber. Sorry. So, I'm a little surprised at the conclusion, because by your data, wouldn't the conclusion really be that adding drugs to the shock added very little to patient care other than increasing length of stay and adverse events at the end of the day? Because really, at the end, they had essentially the same numbers.
That's why I wanted the modified intention to treat analysis, my friend. But I think our argument, and obviously that's why there's equipoise. People love to shock first, especially if you're a resident. But many of us have found the other approach is actually a little more palatable to patients, also frees up the staff to go about their business. And so with the drug shock, which did in fact have better conversion rates, the drug shock approach allows you to hang procainamide, and you don't necessarily have to assemble the team to do an ECV half the time. But they're both very good.
Hi, Ian. Your group had suggested prior that rate control might decrease the success of cardioversion. And I didn't see, did you look at the number of patients who are rate controlled prior?
Yeah, we forbidded whatever rate control in this trial because we'd previously shown it just to waste time, and it was negatively associated with successful cardioversion. So we do not advocate rate control if you're going to go ahead and cardiovert.
Can you dive in a bit more into the length of stay issue, given that the Schurmeyer study did show reduced length of stay with shock only, and there's kind of...
Okay, the question was the length of stay issue. Schurmeyer, who's from Vancouver, showed that there was a reduced length of stay. His study, I'm pretty sure, did not include the placebo infusion. So in normal clinical practice, obviously, that won't occur. So we found, the placebo confounded mathematical comparison of times, but we also found, in fact, even though the actual active cardioversion doesn't take long, our research teams found that there were sometimes delays of several hours before the physician was available to do it because he was off seeing sicker cases. So it really depends, I suppose, on, I think the bottom line is physician preference coupled with patient preference.
Thanks very much, Dr. Steele.
Thank you.
Next, I would like to introduce Dr. Kirsten DeWitt from McMaster University, who's also the recipient of the top abstract from a new investigator, so a researcher who's within the first 5 years of his or her faculty appointment. And Dr. DeWitt will be talking about the incidence and predictors of intracranial bleeding in seniors who've fallen.
Good morning. It's a pleasure to present this study on behalf of my co-investigators who are located in Hamilton Health Sciences, McMaster University and SREMI in Toronto. I have a single unrestricted grant from Bayer, which is for a project unrelated to this study. And this study was primarily sponsored by Hamilton Health Sciences Foundation, and I also have funding from PSI. So this graph shows the rising incidence with age of fall-associated minor head injury. The solid blue line at the top represents the incidence of emergency department attendances of patients who've sustained a minor head injury after a fall. The age starts at 65 and goes up to over 100. The dashed line at the bottom represents the incidence of more serious traumatic brain injury or intracranial bleeding. So you can see the vast majority of people do sustain a minor head injury, but only a very small proportion have anything that might be more serious, considered to be a traumatic brain injury. And as we all know, in the emergency department, the challenge for us as emergency physicians is to sift through these senior patients who present after falling to determine who should have a CT head scan for diagnosis or exclusion of intracranial bleeding and who doesn't require the CT. So we do have some tools at our fingertips. If the patient can give you a clear history and if they qualify for the Canadian CT head rule, then they'll undergo CT. But a significant proportion of these patients are unable to tell us what happened. They might have dementia or delirium. Often the falls are unwitnessed and we don't know the circumstances of the events, and we don't know if the Canadian CT head rule can apply. And in addition to this, there's the thought that these patients are at higher risk of intracranial bleeding because a greater proportion of older patients are on aspirin, antiplatelets, or anticoagulants. And then to make our jobs even more challenging, a number of these patients have coexisting previous stroke, for example. So when you do a neurological examination, it can be tough to tell what's a new abnormal finding and what is a previous abnormal finding. And obviously a lot of the patients are hearing impaired or visually impaired, which makes doing a full neurological examination sometimes challenging. So the aim of this study was first of all to identify the proportion of all the patients who present to the emergency department over the age of 65 after a fall who go on to be diagnosed with intracranial bleeding. And the secondary aim was to evaluate potential predictors for intracranial bleeding amongst this population. So we included any patient who attended the emergency department who was 65 years or older who had fallen within the previous 48 hours. The patients were included if they'd fallen on level ground, either inside or outside, or if they'd fallen out of bed, off a chair, from a toilet seat, or down a single step. The study was conducted in Hamilton Health Sciences at the Juravinski Hospital, the General Hospital, and Mount Sinai in Toronto. We excluded very few patients, but if the patient had been transferred from another emergency department, they were excluded. And if they didn't remain in the emergency department long enough to have their full workup because they had essentially left of their own accord, then they were also excluded. The emergency physicians were asked to fill out a basic research form, and the elements that they completed on this form included all of the variables on the Canadian CT head rule and some additional variables such as, does the patient have a diagnosis of dementia? Are they taking an antiplatelet or an anticoagulant medication? Do they have signs of head injury like a bruise or a laceration? And is their neurological examination normal or abnormal? And the primary outcome of the study was the diagnosis of intracranial bleeding in any of the intracranial compartments, including the extradural space, subdural, subarachnoid, and intracerebral. And we followed each patient for a total of 42 days, and we considered anyone who was diagnosed with intracranial bleeding within those 42 days to have achieved the primary outcome. We measured this primarily with a chart review, and we supplemented the chart review with telephone calls directly to the patients. So this is one of the challenges of the studies. It was very important to me that we included all patients, even if they didn't have capacity to consent, because I didn't want to introduce spectrum bias into the population, and I wanted to include even the most frail patients who might have delirium or dementia. So we had Research Ethics Board approval to include patients who consent, in which case we were allowed to, in addition, telephone them to check if they had been to another hospital and diagnosed with intracranial bleeding. And we were also allowed to include patients who didn't have capacity to consent, but we weren't allowed to call them at home in follow-up. So their follow-up consisted of chart review alone. In total, we assessed 2,176 patients. We excluded 348 patients primarily because they had fallen longer than 48 hours ago, or their fall occurred with a different mechanism of injury. 75 patients declined to participate in the study. So in total, we included 1,753 patients. And you'll see from the flow chart that we had consent to contact about just under 75% of these patients. So I think it was about 26% of patients were included without consent to contact them. Of these patients, 1,017 patients had a head CT scan performed in the emergency department at presentation, and 736 patients had no CT scan at presentation. Overall, during the 42-day follow-up, 5% of patients were diagnosed with intracranial bleeding. The median age was 82. 61% of patients were female. It was definitely a vascular path population. 75% of patients had a diagnosis of hypertension. 19% had a previous diagnosis of stroke. 29% were diabetic. And 27% had a diagnosis of dementia. In total, 82% had a GCS of 15, and 37% of patients had signs of a bruise or laceration on the head. So this slide walks through our 42-day follow-up. On your right, we have, I think on your left rather, I have depicted the follow-up for the patients who had a CT head scan, and on your right, it represents a patient who had no CT head scan in the emergency. So the first thing to notice is that out of the 1,017 patients who had a head CT scan, 76 patients were diagnosed in the emergency department with intracranial bleeding. We followed everybody up, so of the 941 patients who had a negative CT head scan in the emergency department, there were 6 additional episodes of intracranial bleeding. And all of those episodes of intracranial bleeding were detected by chart review. We were able to contact a little over half of the patients. We didn't, as I mentioned earlier, we didn't have approval to contact everyone, and there were a number of patients it was just impossible to get hold of by telephone. So there were additional 6 patients who were diagnosed with bleeding with a negative CT head. And then of the 736 patients who had no head CT scan in the emergency department, there were also an additional 6 patients diagnosed during follow-up, all recognized through chart review, no additional bleeds found with the telephone follow-up. So we had decided a priori that the aim of the study was just to evaluate the potential clinical predictors of intracranial bleeding. So the aim wasn't to build a model, but our statistician wanted us to include every potential variable in this model. So we were able to look at the adjusted odds ratio for each potential predictor. So out of all the predictors that you see here that we evaluated, The top 4 were the only 4 that were significantly associated with the diagnosis of intracranial bleeding. So the first one was a new abnormal finding on the neurological examination with an odds ratio of 4.4. Second one was signs of a head injury, bruise or laceration on the head, odds ratio 4.3. Third was a history of chronic kidney disease as defined by documentation in the medical chart of a previous history of chronic kidney disease, odds ratio 2.4. And the last one was an abnormal GCS compared to the patient's baseline normal GCS, odds ratio 1.9. And then I think it's important to point out, we did evaluate if there was an association between prescription of anticoagulation and antiplatelet therapy, and we didn't find an association, and the odds ratios were actually very close to 1 for both of these variables, and the confidence intervals clearly were very wide. So in conclusion, we found that 5% of this cohort had intracranial bleeding within 42 days of presenting to the emergency department. And we found 4 clinical predictors that were associated with the diagnosis of intracranial bleeding. That was, excuse me, a new neurological finding on examination, a head bruise or laceration, the prior diagnosis of chronic kidney disease, or GCS that's reduced from normal. Thank you.
Questions for Dr. DeWitt?
Yeah, come over.
Why do you think you didn't observe an association between risk of intracranial bleeding and anticoagulants or antiplatelets?
Okay, great question. The question was, why did we not find an association with anticoagulation or antiplatelet therapy? I suspect that there probably is a very, very minor association, and we only had 1,753 patients. So it might have been that if we had, an enormous study with tens of thousands, we might have found an association. I think what we did find is the association is not nearly as strong as we thought. And I think traditionally there has been this idea that warfarin has a strong associated with intracranial bleeding, but nowadays the vast majority of patients are on DOACs, which DOACs have a much lower rate of intracranial bleeding. Yeah.
Let's come over. Sorry, you can hear. So in terms of the actual bleeds, how many of them were actually clinically significant where you'd either operatively intervene or would want to know about them, or the patient died?
Yeah, great question. So I learned a lot about intracranial bleeding in seniors doing the study, and we can't really measure severity in the same way as we do with younger patients. A significant number of patients with large bleeds were admitted to internal medicine wards and died. So those patients were actually, they didn't go on to have surgery, neurosurgery. And so we had 5 patients who had neurosurgery out of the 88 bleeds. And they all survived. There were 14 deaths in total, and they were all admitted to internal medicine and were not offered surgery for whatever reason. There were 14 patients who were discharged directly home from the emergency department. And some of those patients were on anticoagulation, which was held when they were discharged home. 2 of the patients who were discharged home returned. One returned with a worsened bleed and underwent neurosurgery, and one returned with a huge stroke after the rivaroxaban had been stopped, and they subsequently died. So we had 12 patients who were treated at home with their bleed, and as far to our knowledge, they survived and didn't have complications. So maybe 12 out of the 88 were potentially minor bleeds. Yeah.
Sorry, so just a comment. Do you think that the factors that you found associated with intracranial bleed had more to do with the fact that they were indicators of frailty? So for example, let's say you're demented, you live in a nursing home, you've had a fall. Those people are probably less likely to be on aspirin and Plavix because someone has acknowledged or recognized that at that point in life there may be less benefit to having your risk of stroke reduced. Similarly with chronic kidney disease, you know, many of these older patients are, they often have chronic kidney disease, but I wonder if it's just really more their frailty that's putting them at risk of intracranial bleeding and severe falls.
Yeah, absolutely. So I think frailty is a big issue. We are doing a multi-center study now that CIHR has funded, and we're measuring frailty in that study. I think that's an important thing to measure. All of these variables are interlinked, and there is a degree of confounding, so you're quite right. So if you have kidney impairment, you're less likely to be on a DOAC. There's many different ways where these different potential predictors could interact.
I was just wondering why you chose 42 days for the follow-up.
Yeah, great point, yeah. So at the time that we started out, that was really from discussion with experts and prior experience. One thing that I did learn was when you look at all of the delayed bleeds in the patients who'd had a negative CT head scan, there was, with the exception of one patient who actually had a stroke, had TPA, and then developed a bleed on day one, or the day after they came in. All of the other delayed bleeds were after 30 days. And actually a number of those were after the patient fell again. So you could argue that we followed patients for too long, actually, and that maybe we should only be following for a maximum of 30 days. The delayed bleed diagnoses among people who didn't have a CT head scan all occurred within the first week or two.
I noticed that in the patients who did not get a CT scan, the rate of bleed was still almost 1%. It was like 0.85%. I'm just wondering if you could just really clarify your inclusion criteria, because I imagine there's a subset of patients who insist they did not hit their head, for instance, and were those patients included in your study? So could you just really clarify your inclusion criteria?
So sorry, is that in reference to whether they had hit their head or not?
Yeah,
absolutely.
Was this any fall whatsoever?
Yeah,
Was it loss of consciousness? Was this?
Yeah, so that's a really important point. We included anybody who had fallen, regardless whether they'd hit their head or not, regardless of whether they had any symptoms suggested that they hit their head or signs. And we actually did not record whether the patient told us if they hit their head, which is something that we are actually recording now in our prospective study. So the only marker we have of whether they might have hit their head was whether they had a bruise or laceration. Clearly not everybody does have a bruise or laceration after they hit their head. So we know about, I think it was 37% did have a bruise or laceration. So it could be somewhere in the region of half of the cohort had hit their head and perhaps half hadn't. Yeah.
So if the rate is still 1% of anyone who falls, should we be just scanning every single person over 65 who falls? Is a question I think that we have to consider as a group, right?
So the overall rate of intracranial bleeding was 5%, and certainly in the US, they think I'm crazy to do this study because they say, why are you not going to CT them all? My hope is that we can rationalize the choice for CT, so we CT the right patients, the high-risk patients. I appreciate there's a second question here about what do we do about people who have a negative CT and then go on to develop a bleed, and that's almost a separate question. But yeah, I would not advocate for CTing everybody. Yeah. Okay, thanks.
And I'm pleased to be able to introduce our final presenter, Dr. Simon Berthelot from Université Laval, who's going to be talking to us about a comparison of costs for the care of low acuity patients compared to emergency departments and walk-in clinics.
Thank you, Andrew. First, I want to say that sitting beside these three great researchers is truly an honor to me, so congratulations on your work, and I want to thank CAPE for this great opportunity to talk about my work here today. And this work has been funded by the following organizations: le Fonds de recherche du Québec en santé, le CHU de Québec Université Laval, l'Université Laval, le Réseau en santé respiratoire du Québec, and CAPE. Otherwise, I have no other conflict of interest to declare. I'm going to present research results on a very controversial topic, on a very sensitive question. Actually, I saw some of you from the CAPE community tweet about that topic recently in the last few months, and I'm a bit concerned that this slide and the question behind it could trouble some of you just by thinking that there could be an alternative to DED. So, and you know what, as a caring researcher, when we enroll patients, we always have to put somewhere in the consent form a line that says something like, if you feel anxiety or are troubled by this research, you can call this line and get, you know, psychological support. And as a caring presenter today, just seeing this slide, I wanted to say that I brought few lorazepam for some of you if you need them, and a paper bag in case you need them as well. And if you have some trouble, raise your hand. I'm sure Andrew will come by your seat to help you. And otherwise, no kidding. Across the country, especially in Quebec, there have been few decision makers that have set up policies. So low acuity patients would go preferably directly to walk-in clinics or primary care practices instead of visiting DED. And behind this, the rationale is that walk-in clinics and primary care practices are cheaper and offer a care that is comparable in terms of quality. But looking at the data, the scientific literature, the evidence is not that great about costs. The data on cost are scarce or contradictory, and there are obviously almost no data about quality of care. So we thought that conducting a study about this was essential. So the primary objectives of the study I'm presenting today, which is a part of a bigger research program, was to compare the mean cost of care per patient in DED and the walk-in clinic for 3 conditions: upper respiratory tract infection, URTI, in the following slides, urinary tract infection, UTI, and low back pain. And we also explored if there could be quality of care issues that could help us determine the appropriate care setting for low acuity patients. So we conducted this study in the fiscal year 2015 and 2016 in Quebec City, including 2 institutions, 1 academic emergency department receiving more than 45,000 ambulatory care visits per year, and a nearby walk-in clinic receiving more than 30,000 visits per year. And in terms of the design, we had 2 phases. The few next slides will describe more the design, but a time-driven activity-based costing method and a retrospective cohort study. It's hard in few slides and a limited time to describe what is the time-driven activity-based costing method, but essentially you need 2 parameters. The first one is you need to derive from the accounting books from your institution the cost rates of each resources you have: nurses, physicians, nursing attendants, and you get a rate for each resources, including the machine, the X-ray, the CT scan, in terms of dollar per minute. And then you go on field and you do you collect data on a prospective cohort. You measure on site. You measure the time of each care processes, for instance, triage, X-ray, physician assessment, and we measure more than 2,000 care processes in both sites. And for the next slides, you need to know that the costs that I will show here include physicians, consumables, and overheads, which have been the main limitations of many studies down there in the literature about the comparison between these 2 settings. So for a quick example for you to understand, when you conduct a time-driven activity-based costing, let's say that we estimate the cost of ED triage. So you have the nurse who is responsible for the triage. The cost of a nurse in my institution is $1.02 per minute. The duration of the triage, according to our measurement, was the median time is 7.1 minutes. And then you multiply these 2 parameters and you obtain the cost for the nurse. And then you do the same for the consumables. The consumables are the needles, the gloves, the paper, everything. And you get the cost for the consumable, and then the overheads, because the general direction of the hospital, the maintenance of the emergency department, you need to count that in the cost. So that's the way we allocate as well the overheads, and for a total cost of around $10 for ED triage. You do this for all care processes: physician assessment, x-rays, and then you get a list, a complete list of the cost of care in your institution. And then what we did is a retrospective cohort study. We extracted manually the data on each patient, and there was an overlap for 10% of patients for the reviewers, the assessors. So the kappa statistics assessing the inter-observer agreement was pretty good, with 0.85 for the variables extracted. And then we included patients with targeted diagnosis, URTI, UTI, low back pain, consecutive adults that consulted in the year under assessment, the first visits for their problem, and they were ambulatory at all time from arrival to discharge in the ED and, of course, in the walk-in clinic as well. To compare the costs, we risk-adjusted the estimates using a generalized log gamma regression models, and we compared the quality of care indicators using Pearson chi-square. So a few results for you here. This is table 1, essentially to show you that there wasn't too much difference between the two groups. We recruited 409 patients with a mean age in both groups about comparable, around 36 to 40 years old. Most female in both sides, slightly more in the ED. In both groups, most patients did not have any comorbidities associated, except for 6.8% in the ED and 2.7% in the walk-in clinic that had significant comorbidities such as diabetes and heart disease, and as shown by the Charlson Index score of 2 and more. And there were more asthma patients in the ED as well. Otherwise, the vital signs were pretty much the same in both settings. We adjusted the cost estimates for all these variables later. This is a distribution of all patients according to site and condition. Just to say that our sample size calculation required us to recruit at least 10 patients in each site. So we largely went over this limit. So the primary outcome measure here are here, the comparison of adjusted mean cost of care. So for URTI, as you can see, about in the ED about $80, in the walk-in clinic about $57. UTI the same, approximately $78, $79 or so for the ED, $53 for the walk-in clinics. Low back pain, similar relationship, $85 in the ED and $60 in the walk-in clinic. For the difference, around $25. For those who are excited by p-value, it was largely significant with a p-value of 0.0001. And as I said, we adjusted all these measures, all these estimates for age, sex, comorbidities, number of regular medications, and vital signs. In terms of quality of care indicators, we checked if the for the URT. Okay, so I didn't say anything yet, but you can see. So antibiotic prescription for URTI in the walk-in clinic was 44% of patients receive antibiotic prescription for this diagnosis, and compared to 5.8% with a p-value largely significant. And in terms of chest X-ray use, it was on the edge of being significant. I guess it's simply a power issue. But we tend to use more X-ray than the walk-in clinic. When we compare compliance to guidelines for use of antibiotics in UTI and the use of colon X-ray for low back pain, there wasn't any significant difference between the two groups. Of course, the main limitations of this study is, I should say first for most of you, that those are Quebec data. Which could be different in your own provinces. It's only 2 sites. So in terms of quality of care indicators, I would refrain concluding definitely about any official issues there, although it raises some questions. But for the cost estimates, I would say since most of the cost is related with the physician costs and nurse costs that are all negotiated centrally by the government with the different associations, I will do this study in other sites, and I'm expecting the relationships between the 2 sites and the cost will be quite similar. Of course, these are observational data from inconstant quality of patient records, and finally, we did not assess patient out-of-pocket expenses. We will in future iterations of this study. In conclusion, what we demonstrated is that consulting in the walk-in clinic is about $25 per patient less expensive. So for the other part of Canada, it's maybe 1.3, 1.2 times more expensive in the ED. There could be issues of quality with quality of care, but that needs more studies, and we're planning a multi-center study. Hopefully, CRHR will give us the funding next month. You will pray for me, I'm sure. So this is my research team. I want to acknowledge their tremendous work. And for now, I will be open for your questions. Thank you for your attention.
So I understand the logic of right care, right place, right time, although I look at the $25 difference and I wonder, is it a real number? And what I'm getting at is, if I look at our emergency department, I'm not sure what the budget is, but let's say for sake of argument, it's a $5 million budget. Whether a person comes in or not doesn't change that budget. The budget's exactly the same whether we look after their 500 patients. So of the consumables, the overhead for nursing, the overhead for housekeeping, the overhead for all of those things is there regardless of the number of patients, unless it goes up significantly that the entire budget goes up. So is it a real number?
In terms of a real number, it is a real number, of course. It is based on true expenses. Those are true costs. In terms of what you're saying, there are some costs of simply keeping an emergency department open. It is obvious, but there are still some variable costs that, and I have a few slides later that I want to show you. This is the proportion of cost of care per cost element in the ED, and as you see, more than 60% of the cost is related with doctors, and doctors in my province are fee for services. Partly fee for services, not completely, but at least 50% is fee for services. For that part, it's certainly something that can be it is variable depending on who consults and who do not come. And of course, all the consumables here, it's not written, it's 3%. These are totally variable costs. And in terms of investigation as well, these are totally variable costs. And in other analysis I'm currently conducting with the health economist on my team, we're going to assess the marginal cost, and we're going to go deeper, and we'll be hopefully able to better answer to your question. But there are still variable costs, that's what you need to understand. And these are of course, true cost, and is cheaper than I was expected, I think, but you have to remember that those are ambulatory patients, low acuity patients. They do not require too expensive care.
Did you look at whether the fee charged by an emergency physician in a fee-for-service model is more or less than a fee charged by a physician in a walk-in clinic?
So could you repeat that, please?
Did you look at whether the fee charged by an emergency physician is the same, more or less, than a fee charged by a walk-in clinic physician for the same complaint?
Yeah, no, fee charge for the same complaint, they are not the same. I mean, okay, I have another slide for this. Okay, so the way the time-driven activity-based costing method works, it is not based on the fee for services. It's based, you take for a year how much it costs for all the physicians in the walk-in clinic, and how much did it cost for all the physicians in the emergency department. Then you divide this cost by the number of minutes the physicians were working for patient care, and then you obtain a rate. And this is the difference. At the fourth line, you see physicians in the emergency department cost $5.15 per minute, and compared to $3.44 per minute, dollars per minute in the walk-in clinic.
Thank you.
Hi, thanks for this. I'm glad you talked about marginal costs, because I think that's one area that would be really important to funders as well. In terms of the time-based derivation, your consumables and overheads particularly, you didn't control for CTAS and acuity. And I'm wondering if you should look at that, and suggesting you can look at that in the future, because I'd say you can assume that the consumables and overhead, even controlling for time basis, is equivalent for URTI, UTI versus the entire spectrum of ED patients. So I think that may be another refinement you may want to look at.
Okay. For the first part, the CTAS, it was not possible to control for it since in the walk-in clinic, the CTAS was not, it was there for some of the chart, but not all the charts. So it was not possible to adjust for this since it was an inconstant variable. But I think through adjusting for vital signs, comorbidities, we have some kind of an adjustment for severity and burden of disease. For the other part, I'm not sure that I remember you said, for the overheads and consumables, the way we allocate the cost for consumables and overheads are time-based, as you said. So the more time you spend with the patient, the logic behind that is that we assume that there will be more consumables and more overheads in this. It is not a perfect way to allocate the cost, but as you see in this, and as you see in these pie charts, it is a very small part of the total cost, so I'm not expecting that would be a big issue of variation if we had another way to allocate the cost. I'm not sure I did answer well your question, but I'm available if you need more details.
Really complex issues in terms of the studies of these things, and when I'm looking at your slides and see that the quality of care measures in terms of antibiotics, for example, for URTI, if there's a $25 difference, but you're prescribing the antibiotic so many more times, like so much more frequently, is that cost not automatically eaten up and accounted for by better quality care?
Is that what? Could you repeat the question?
If you go to the emergency department, it costs $25 more, and then you end up getting an antibiotic so much more frequently from being in a walk-in clinic, is not the difference gone immediately?
Yeah, I mean, I want to specify that I'm not saying that we should direct these patients in the walk-in clinics. I'm just providing data for you to have this discussion and for the decision makers to have discussion. And in terms of quality of care, as I said, I think it's only two sides that might be related with culture, local culture and habits of prescriptions. Right. So, but yeah, I mean, it's a big issue to prescribe antibiotics to RTI and the OCDE in English, I don't know what it is, but in the world there is one big indicator that is suggested for healthcare is that the use of antibiotics in URTI, and obviously this is a failure for this walk-in clinic site, and I think a multi-center study is certainly indicated to go beyond that with more sites and more indicators, outcome indicators, mortality, return visit, and things which I didn't show here, but the next research I'm conducting includes all this.
Yeah, congratulations on doing that and having those quality measures in there, because I think that's where all of us think
it's essential. Yeah, I agree. Thank you. It's done.
Folks, I think we're gonna need to wrap up and move on to the rest of the day's program. I wanted to thank and congratulate Drs. Berthelot, DeWitt, Steele, and Perry for their outstanding work today. Thank you all for joining us. And thanks especially to Shanna Scarrow and Kelly Wyatt at the Cape office who did all the heavy lifting for this year's research competition. And again, please support the EMAF by coming out to Docs at Rock tonight and with your annual donations. Thanks very much.